Hi, everyone. Today we have with us Micah Kassahun to talk about some billing and coding issues and talk us through some common circumstances. Micah joined the Indiana Rural Health Association in September of 2019 as a data coordinator. He has a master's in public health degree and has been heavily involved in data analysis, management, and collation projects. Currently, he is focused on data-related projects such as the Crossroads telemedicine program and the Indiana Rural Opioid Consortium, with its focus on the opioid crisis in prevention, treatment, and recovery. His work with the IRHA has expanded his skills with data collection software. The diversity of projects he is associated with has added a level of versatility to his contributions. He is now dedicated to applying data analysis practices with increasing effectiveness and aims to progressively incorporate statistical analysis software to further streamline dissemination of data across multiple projects. And to introduce myself, I am Luke Wortley. I'm one of the program coordinators at the Indiana Rural Health Association and the resource development coordinator. And I will, without further ado, hand it off to Micah.
All right. Can you see my screen?
Yeah, it looks good. I think you just need to go in present mode and then you'll be fine.
Sure thing. All right, should be loading very quickly. All right, how is that?
Are you using two monitors by chance?
I am. I can switch that over briefly.
There we go. No, that looks good.
This looks good. Okay, perfect. All right, everyone. Thank you so much for tuning in. This has been somewhat of a mini passion project for myself. I've been just doing my best to learn and kind of have a general understanding of what goes on in the medical, just billing and coding world. I would still like to say I'm somewhat new at it, so I've been going through everything kind of at my own pace and digging in, diving in, trying to take some classes here and there just to get an overall holistic view on what all of this has to do, what this has to do with. I also recognize that some of you may already be familiar with some of these elements, and that's okay. I just wanted to kind of walk through with a primer as to what to expect and just some of the the pillars of understanding regarding all of this information. So yeah, thank you so much, Luke, for just introducing myself. I am a data coordinator, and I actually work with InROC, specifically with the opioid crisis regarding our implementation grant. So I've been able to have access to view a lot of different behavioral health codes and what those mean, and how to better serve our rural communities and have a general understanding is what are we coding, what are we seeing within these fields, and additionally, how are we getting reimbursed for them? What does that process look like? And at the same time, what is the even purpose of having these codes? Additionally, I also work with the Crossroads telehealth program, and in doing so, I've been able to learn also, telehealth coding and what that looks like, and what key codes have been even added into today's coding world, just to meet, the different the crises such as COVID, different types of barriers to access for care within rural communities. So hopefully I can just shed a little bit more light on that today as I move through these slides. So just to open up, I don't have any conflicts of interest whatsoever. I just want to make that clear. I'm not getting a kickback for any of this. This is solely just out of working with IRHA and just learning the ins and outs of the many different pieces of information regarding all of this data and everything like that. So kind of the agenda that I want to go over is that I'll be talking about just an overview of ICD10 codes. Then we'll go through CPT codes, also known as current procedural terminology. Also, we'll talk about the common substance use disorder codes that are found within CPT codes that we use regularly within rural health. And then the health common procedure coding system. And this is commonly called HITP. I just like to abbreviate. It's really simple. Again, you might be really familiar with this already if you're watching right now. And then Medicare reimbursement and kind of the eligibility requirements regarding all of that. So kind of jumping straight into it. So when we're talking about ICD-10, we naturally are referring to the International Classification of Diseases, the 10th revision specifically. We've phased out of the 9th. And so I don't know if there will be an 11th anytime soon. So I haven't been following up on much reading on that. But if we look at just ICD-10, it just functions as a really nice tabular list for medical professionals to understand, the different diagnoses available that can be transmuted upon any type of patient ailment or problem that they're going through. So, in kind of similar to the adage when Apple was becoming really familiar for the development of apps and everything like that, and people said, "Hey, there's an app for that. Hey, there's an app for this. There's an app for that." I want you to take that mindset and apply it to when we look at diagnosis, the different diagnoses. Like, there's always a diagnosis for that. There's always a code for that, and that's what I want. That's what really is helpful about the ICD-10. It's just kind of a dictionary of what it is, of the different ailments, problem areas, and different types of struggles that certain patients might be coming forth to see a medical professional. So there are 4 key sections within just the ICD-10 alone. So we have the index for diseases and injuries. Then we have a table of neoplasms, which is just for cancer-related ailments. And then table of drugs and chemicals. I will say this is very extensive. It has like poisons, noxious plants, toxic agents, you name it. Anything that is deemed a drug or a chemical or anything that could do harm to the body of that sort of nature. Very extensive and exhaustive list. And finally, there is an external cause of injuries index, which this refers primarily to environmental circumstances and acts of violence. And again, there will be specific injuries regarding to, like, if someone was attacked and for some reason they had a bruising on their right arm. There is a specific diagnosis code for that through the ICD-10. So hopefully that all makes sense. I also will be having towards the end a little bit of time for question and answer. I hope that's okay, Luke. If not, the recording is available, and I will make sure to have my PowerPoint slides available upon the completion of this. So here I just wanted to show an example of what some ICD-10 codes look like. Here we have, this is talking about specifically I want to look at J44.0. These codes usually will start with a letter, and that letter will dictate which area within the coding book that you start so that you can begin diagnosing and evaluating the patient and the claims of what it is that they're going through. So specifically, if we look at where it says J44.0, it talks about chronic obstructive pulmonary disease with acute lower respiratory infection. So there's a 0.0 after that J44. The 0.0, anything after the decimal, lends itself to tell you more about the severity of the diagnosis, how specific the issue is, and if anything, the more numbers after the decimals you have, the more granular you can get, and specific that you can get this diagnosis code. So it's always important to get the most specific version of the code, because that will help you later in your reimbursement process, so that CMS knows exactly what it is you're billing for, and they can view whether or not the things that you're billing for are medically necessary and reasonable and responsible. So if we look at J44.1, we have the same exact issue, which is chronic obstructive pulmonary disease with acute exacerbation this time. So there is a new element added, and that's just because you changed one number after the decimal. So it's very important when coding, your accuracy must be just perfect, if not just impenetrable in all forms, because that could be the difference in whether you're getting your claim fully submitted and fully reimbursed, or if you have to have that claim just rescinded and you'll have to start that process all over again. So that's something that always needs to be in the back of your mind. Accuracy will always be key, and making sure that you're submitting your claims in a timely manner will always help you go around that process. And then finally, we have J44.9. And so usually when you hit when you hit the 0.9, that would just be chronic obstructive pulmonary disease unspecified. There's not really the doctor or the medical professional or the nurse or the NP may be looking at the site, and they may not have a specific way to categorize that. So they just might put it as unspecified, and they'll move on from there. So hopefully that's kind of a helpful understanding of kind of how ICD-10s look and how they function and what the overall purpose is. So again, it's just for the identification purpose of whatever it is that the individual or the patient is going through at that point in time. So obviously the most important element out of this comes to mind is what are the primary codes for substance use disorders. So as we focus on this, a lot of the times when I am looking at my data spreadsheets and I'm evaluating what is necessary and what is beneficial for the frequency tables that we're establishing and reporting to HRSA so that we can disseminate the proper data elements to them, we always want to focus specifically on our target area. So with InROC and the implementation grant, I look at specific SUDs. So any SUD starting within the category of F1 followed by, say, if it was like F19, that will be its own specific substance use disorder that we're dealing with. And it continues to go on after the decimal with another 3 decimal places, again, which will make it more granular and more specific so we can get reimbursed on the very, very specific issue of what is going on. So the number 1 refers to the mental or behavioral disorder attributed to the psychoactive substances use. And then the first X after the number 1 denotes that specific substance. And then after that, as I said before, all subsequent X's after decimal denote the severity. So this could be low severity, then it will go to moderate, and then moderate high, and then just straight high severity. And so here's a great example. F14.280 is a moderate severe cocaine use with anxiety disorder. So that's usually just how it's read. If the 0 was left off of that, it would mean something entirely different. So F14.28 is completely different than F14.280. So again, I'm just emphasizing how specific that your coding needs to be. Additionally, leaving anything or adding anything could be a cause for missing a claim payment or reimbursement with that. So here's a common list of all of SUD diagnosis codes, especially within the rural setting, especially if you're working with behavioral health, from a behavioral health aspect. F10, we have the use of alcohol. And so when I say use of alcohol or opioids, I'm not just saying the usual use, I'm saying actual abuse, but just for the sake of everything, I just put in use for here. So F10, use of alcohol, we have use of opioids, cannabis, sedatives, cocaine, you name it. Every single possible drug, inhalant, barbiturate, they all exist within the ICD-10 of some nature. So you can always guarantee that from F10 to F19, all of those codes within there are reflective of an SUD. And so these are commonly used throughout the behavioral health realm. I see this also currently within our Crossroads program with our telehealth program. And it's been very helpful to use specific telehealth codes and just telehealth services in general when dealing with SUDs. And I'll get into that a little bit later. So this is just a really great list just to have on tap and just to know of, and just to save for later when you're trying to understand the scope of the SUDs you're dealing with. So I also included a little note here saying that you should expect recurring encounters in your EMR systems for behavioral health and telehealth. A lot of times I would get confused as to why I had so many of the same patient within and so many different data services within my data spreadsheets. And I was starting to understand when you're dealing with addictive substances, naturally the patient needs to be seen multiple times as they're walked through the proper treatments. And they're going to different therapy sessions and different meetings with other medical professionals. So because we are dealing with addiction-based substances, it should be understood that your EMRs may have an exhaustive amount of encounters for one specific patient. I know that with my Crossroads program, for one patient alone, I have 62 encounters. Now that's extreme and that's a very high outlier, but that just can show like there's a huge fluctuation between the number of visits, but usually you will see a higher number of visits up between like 15 to 23, somewhere around there. So just be mindful of that. And it's nothing to be scared of, but it's very much indicative of some type of substance abuse. And then you can point yourself to those specific ICD-10 codes. So here's a list
Micah, real quick, we had a question from chat. I didn't really want to wait to share very end,
Of course.
is there something related to synthetics?
There are. I believe I had something in here farther down. I I don't know if I actually put it in, but I've read something on that. So with synthetics, I know the different types of drugs that are being, pumped out are beginning to change, and different codes are coming out. And so I don't know what the specific ones are, but I'm sure there are. But there are also what are temporary codes. And so temporary codes will come in they're a different category of code that is released by, say, a local region or a local area. And in doing so, that code can eventually become a mainstream, generally accepted national code if it gains enough traction and if it is deemed as necessary to properly bill for. So again, that can change. These are not necessarily, no code is safe from being changed, because when we're dealing with drugs, everything is it's like water. It's constantly moving, it's constantly ebbing and flowing based on what's being used, and what's available to individuals who are taking that. So the codes may change, and I know for sure they've been added into basically the dictionary of those different ICD-10s and the SUD codes. I don't have them exactly, but I know they in fact exist. And so that could also be going back here. I think I had it here. Yeah, going back, depending on what the chemical makeup of the drug is, it may be found and classified within the table in drugs and chemicals. So that would be the poisons, noxious plants, toxic agents. And so that would probably be linked, and there a code could go back. It's not saying like specifically cocaine. It could be, what if someone was mixing, say, rat poison with heroin or different things like that. So things can change, and different SUD codes can be applied to a specific instance. So that might be able to address, hopefully that addresses kind of the question regarding, manufactured, synthetic drugs in that regard. Does that help? Hopefully.
We'll also have time for Q&A in the last 10 to 15 minutes of this call, and say where it says that, yes, that does help.
For sure. Okay, great. That's wonderful. All right, so now moving on. So here's a list of just some, this is not exhaustive. I didn't include all of them because there's a lot. So there are naturally many comorbidities associated with SUDs. So for this example, what I've seen within my own work, I've seen a lot of anxiety disorders, and specifically anxiety falls into the category of F41. So anything that was starting with F41, it's anxiety. And so from there, that includes GAD, generalized anxiety disorder, panic disorder, and PTSD. And then, of course, naturally, again, because this is not exhaustive, there's also other mental disorders, including depression, bipolar disorder, ADHD, psychotic illness, and just a whole slew of other mental disorders. And I was doing additional reading and was learning there are genetic predispositions to, when diagnosed with the mental illnesses, to being at risk for the use of different substances. So that also needs to be taken into account, that when a physician, NP, any type of licensed professional that's working, be prepared to apply multiple diagnoses onto a specific patient. Because I know that with my data spreadsheets, I make space for 4 diagnoses. Naturally, you have a primary and secondary, which is somewhat standard, especially within EMR systems. But with IRHA, how we've set things up, we add a tertiary and quaternary spot for just additional comorbidities that we can also learn and understand, that could be other things to watch out for. So know that not one diagnosis is going to be enough just to diagnose and understand where your patient is at, because you always have to take into consider a holistic view when doing this, or then you don't get a holistic treatment plan. And so that could be just as damaging as to misdiagnosing, because if you're not providing those resources, you've already created your own barrier within the process. So just a little side note, just to add that into that. So be aware of the different comorbidities Like, for example, if someone is doing intravenous drug use, or they're using like with heroin and using needles, sure, they're addicted to heroin. And heroin abuse has its own SUD. But on top of that, you also have to consider, what if they're sharing needles, say with a partner, or with friends or something like that. Well, then you want to take into consideration HIV and AIDS awareness. So that's another diagnosis that would have to be at the forefront of the discussion. And if you don't, then you have an issue of there could be an HIV epidemic, or of something of that nature. So it's always very important to look at the comorbidities, and one size does not fit all. It just does not work like that. So we want to take a very fluid approach and make sure our awareness is just on point at all times. So now, when looking at OUDs, I'm talking about opioid use disorders. We classify OUDs as a substance use disorder, but based on what's been going on just within the state of Indiana and the surge of opioid use, we kind of extracted OUDs from SUDs just to make them their own category so that we could specifically evaluate this issue at the ground level. So specifically for opioids, we know they are at F11.1 and F11.2. Again, the following X's after the decimal and after that number dictate the specificity and the severity of that disorder. So we have opioid use at F11.9, poisoning, T40, XXXA and XXXD. These letters that are tacked on, again, they add another level of, I want to say, granularity, so that we can, again, further evaluate. If you continually see things tacking on afterwards, know that it's done for a reason, for a purpose, always. And then when we're looking at adverse effects of OUDs, that will be T40, XXXA and D. They're just the same thing when related to poisoning. So adverse effects and poisoning do work in tandem. And then long-term use of opioids. This one is a little bit of an outlier in of itself, which is Z79.891. So that's just looking at the, I'm not exactly sure the time frame for how long one has to be using opiates to be considered to be diagnosed for this very specific code. But I just wanted to include this in there because, again, this is a chronic issue. So I kind of just deemed that appropriate. But again, I'm not exactly sure about the exact time of how long it needs to be for you to get that diagnosis. All right. So moving on from after ICD10, because we're going to be going through, again, the three main pillars for myself, which are ICD10, CPT, and HITP. So now moving to CPT, which is the current procedural terminology code. This describes services provided just by medical professionals to patients. So with ICD10, we know the diagnosis, we know what's going on in the patient's life, we know what they're experiencing. Now we're looking at the CPT code, which is, what are we going to do about it as a medical professional team? How do we go about it? So it's provides shorthand notation that is usually universally understood by providers, payers, administrators. CMS is very aware of it because that's just the process that we use. And so part of the healthcare is part of the HITP code set. Again, we'll get into that in a little bit later because HITP and CPT codes work together. And then on top of that, there's 3 categories within CPT codes alone. So let's dive into that super quick. Hold on one second. All right. So looking at these 3 categories, we have category 1. These are generally accepted by our healthcare system and by a variety of clinical locations. And then there's category 2. These are used for performance measures, just for quality of service, accountability. These are represented as a 4-digit number with the letter F at the end. So typically, I'll just say when dealing with CPT codes, you will be dealing primarily with category 1. But this is just to keep it, just make it an overall understanding and an overall summary. And then category 3, this is similar. Regarding to the question of manufactured synthetic drugs. These are category 3s. So they identify services, procedures, and other technologies that are newly emerging, represented as a 4-digit number with the letter T at the end. So if you see the letter T after 4 numbers, you know that this is category 3. This is a newer code. And it also has the potential to be changed to a category 1 code if it becomes widely adopted and understood. So if there was a public health, so for COVID became a brand new thing to all of us about 2 years ago. And so when it comes through, they created its own code. I don't have that actually in this slide, but they created their a code that was added in and appended to the entire dictionary. So that it's just helpful to know that we have different types of codes, different categories for each, because everything changes. And so as things change, we want to adapt and provide the most up-to-date information. So there, within CPT codes, we have general subsections. And so that will be E&M codes, also known as just evaluation and management, anesthesia, surgery, radiology, pathology and laboratory, and medicine. And so each of these subsections are divided into more specific areas. And so each of the 6, they also address digestive, nervous system, all of the key body systems that exist. Again, this is very holistic, very specific. If you can think of it, it exists. I guarantee it. So here's an example. So this comes from a textbook from the American Academy of Professional Coders. Here it talks about 20100, which is the exploration of a penetrating wound. But that would be a separate procedure. So when going through the actual textbook, you would see that 20100, that is the base code. If you notice, there's a semicolon right before the word neck, meaning that anything that is before the semicolon is represented as the base code, and it's just a really easy way to represent it. But specifically, this is for the neck. If I go to 20101, that means it's exploration of penetrating wound, but in the chest area, and it becomes the same thing for 20102. It's the exploration of the penetrating wound for the abdomen. So again, this was developed, the addition of the semicolon has been used and is widely understood as anything before will be the base, everything after is the specific area to which it is applied to, of what the medical team is doing to examine and view the site of the diagnosis. And so there are full descriptors for all of these. The numbers do not specifically go up from 0, 1, 2, 3, 4, 5, 6, not like that, but just based on what is available and what is understood as common medical practice. And so from that point, in numerical order, they increase over time. So now, what are the primary billing codes for SUDs and just overall substance abuse? Really common ones are anything that starts with a 99 will usually be an evaluation and management code. And these evaluation and management services are basically outpatient visits where the patient will go to the provider's office for their appointment. And here there will be a number of evaluations that just take place. So you can think of it as just a regular doctor's visit, obviously, because we're not dealing with inpatient at the moment. So for this 99202, which has actually been a new code, because 99201 used to be the base code, but now that's been phased out. And so as of January 2021, 99202 became the new base code for an outpatient visit that's going through evaluation and management specifically for a new patient. And then within here, you don't have to read all of this, but just for the sake of the example, the provider focuses on a problem-focused history, a problem-focused examination, and a straightforward medical decision-making. And so this will be done between 15 to 29 minutes. And the problem, it tends to be very limited, very minor, not a big deal. And now, as you notice, when I look at 99203, it includes everything from 99202. So it's an office or other outpatient visit. And then upon that, now it's not a problem-focused history, it's an expanded problem-focused history. And so as you can see, as the number increases, some of the wording changes because for this specific set of code, things are increasing in severity. They're increasing in the type of medical decision-making process. They're increasing in the amount of time it takes for the medical professional to work with the patient. So this is common for SUDs because this requires either through telehealth or through in-person visits at the provider's office for the individual to make multiple trips out or have multiple appointments to go through the chronic disease of substance use disorder. So this is commonly used. And here we have the next levels. You have 99204, which is 45 to 59 minutes with increased severity, and then 99205, which is an hour and a little bit beyond to very high severity, with very comprehensive examination and just a high level of medical decision making. The same thing, this is for now established patients. These are CPT codes for established patients. I will also like to mention that a lot of this becomes pretty repetitive and can be somewhat boring to an extent. I've talked to a lot of people. Not a lot of people are excited when it comes to medical billing or coding, and for good reason. But again, we have to look at this as an established structure for the sake of submitting claims and receiving reimbursement. So everything may seem very monotone and very non-exciting, and it's not the exciting world of healthcare, but it's the necessary healthcare to keep everything moving and established. So again, going back, we have 99201, 12, and 13. Again, very similar to the new for new patients, but this is all just for established patients. Again, it goes to 99214, 99215. Excellent. So now hopefully this is a more, it's a cleaner way to visualize. I put all the data that we just talked about before. This is now put into a nice table. Again, I'll make this available to the rest of the IRH team to send out at the conclusion of this. But hopefully this kind of provides a very easy to read, understanding of like CPT codes, the medical decision making, the level of complexity, the amount of complexity and data to be reviewed, and also risk of complications. All right, and then I thought this was also important to provide consultation codes, also known as just getting a professional second opinion. So this would be 99241 through 99245. And so here we have different levels of the office consultation. And here we have some of the, the costs when we're looking at RVU, and we're also looking at whether you're in network versus out of network. And so some of these numbers here, it was very difficult to find some of these numbers. So finding specific numbers I've always had trouble with. And so this was probably the first time I was able to actually find reimbursement information regarding consultation visits. All right, now moving on to HITP, Healthcare Common Procedure Coding System. These codes begin with a letter, and this is letter A through V, followed by 4 digits. So there's an example right there. There's 3 levels. So level 1, these CPT codes used to identify services or procedures provided by medical professionals and healthcare facilities. This may sound a little confusing, but a lot of times CPT codes and HITP can be interchangeable. It just depends on what is actually going on with the patient. And they've established specifics in how to understand them. So when we look at, say, HITP and CPT codes, if there is, I have it in my notes, if the HITP code and the CPT code are the exact same, then you can go ahead and you would use the CPT code. I don't know why that is exactly. It's an alternate form of providing, the services that are going to be done along with the equipment that is necessary to complete the task. But for a lot of the services, CPT codes and HITP will have, they're 2 different books, but they'll have the exact same information. And that's completely dependent on the specific code and the type of service to be provided. So if for some reason you're unsure which code to use because you see them in both handbook or online or wherever you get your information regarding different coding practices, if they're the same, you would want to jump with the CPT code. However, if the primary insurance provider of the patient is Medicare, then you would want to go with the HITP code. Again, that's just been the standardized rule, and that's kind of just where it's sitting at the moment. And then if both codes are just similar, so if the verbiage is not exactly the same, but like the general idea is there, but there's and it's non-identical procedure or service descriptors, then you would just use the HITP code, and you would just move from there. So it jumps around a lot. It can be kind of confusing, but there is a set system in how everything moves in that regard. All right, so HITP codes, we've got A through V. There's a lot of HITP codes. I'm telling you, this can go deeper than you want it to be, and will always be more complex than you want it to be. Again, keeping everything simple and established so that our reimbursement process can be as smooth as possible, and getting and making sure our claims are accurate and medically necessary. So we have A codes for transportation services, medical and surgical supplies, B codes for enteral and parenteral therapy, C codes, temporary codes. We have OPPS, E codes, and this is specifically for durable medical equipment. And so I'm not going to go through all of these specifically, but if you were just for some reason just to look up like, hey, what are all of the letter codes for HITPs online? They're readily available, and you could just jump on top of it and be able to know this is what this is for. But the whole point of the lettering system is just to know, hey, this is the established theme of these codes, and you just go straight to that if it applies specifically to the diagnosis or to the CPT code that you are trying to address within one of your patients. And so they all exist for every single one. So when we look at rural health, G codes and J codes will be most important. So we're looking at, for G codes, if you're looking at rural health, we know that telehealth is huge. It helps run and push things forward within rural health. So telehealth naturally fits within procedures and professional services. And then J codes, when we're dealing with the opioid crisis, that's when we talk about drugs administered, other that are intravenous, and that are other than oral method or chemotherapy. So the greatest takeaway is G codes and J codes, they will be your best friend in regards to HITP coding. And then finally, not finally, but LMPQ codes. I know maybe some of you are questioning why I don't see all the letters. That will be addressed very shortly. And so here we have RSTV codes. Again, diagnostic radiology, temporary national codes, other national codes established for state Medicaid agencies, and then V codes. And so again, I put a note at the bottom is there are no HITP codes for letters D, F, I, N, O, or U. I'm not exactly sure why that is. I'm sure there is a reason, but that is just the way that it is. It's still A through V, just without those 6 letters. And so common HITPs in rural health, obviously we talked about some G codes. We can see here for just care management of just high-risk diseases that are common, G2064, meeting 30 minutes with physician, G2065, very similar, and then G0511, general care management for FQHCs and RHC claims. We'll see that that's very common as well. Again, I tried to make sure to engineer this and write this so that, again, this points back to rural health. So hopefully you'll have access to this so that you can look back at different ways that you can be, submit claims and reimburse, and just make it kind of seamless and have this, filed away for your own evaluation later. Telehealth, again, I think one of the greatest innovations for rural health. Again, we have specifically telehealth visit online only as G0210, telehealth visit online only, telehealth audio, so no visual. And then again, different types of telehealth, each specific to the type of telehealth you're getting, whether you can see the primary care physician or they can see you as a patient, and vice versa. And then specifically G0071 This is very helpful when submit with FQHC claim for payment can be done using only G0071 or with known payable service. So those are some really common HITPs that are found within rural health. Here is just the decision, HITP's decision tree for whether a code needs to be added or revised. Again, this is a very fluid process and will always be changing with the times regarding it's like if there's a new disease out there, there's a new drug out there, is it a new service or just a new innovation related to medical technology that comes out. Naturally, when we look over here at tier 1 on the top left corner, was the application timely and complete? This just represents was the claim submitted on time? And again, in claims processing, that's always going to be like the number one thing. Was it done on time? That will always be your number one thing you want to focus on. But then we look at, is the appropriate code jurisdiction? It's not capital equipment that you're billing for, XYZ, and it just continues and it's the classic yes or no method. So this might be really helpful if you want to take a look at this later, just to evaluate and run through this tree for yourself when coding and working with your own staff. This may be beneficial in just understanding how different organizations understand and they add or revise different codes. Or if you see a code that needs to be added or revised and you want to send something over to CMS or a local MAC contractor within the local area regarding different codes like this. So this is just something just to look at more for an educational tool. So here, there's just a nice comparison between HITPs and CPT codes. Here we have a description of the value divisions, the creators, and the reasons for use. This is just a really nice way to put it together and consolidate all the information I've just been seeking about. So this is just a good graphic just to hold on to. Again, HITPs, their point is description of the delivering services, and the CPT code is the actual services that medical workers provide. Again, they're very, very similar. You could probably just shuffle some wording around, but they'll always be somewhat similar. And then here, again, I kind of talked to this already, if you have identical procedures, use CPT, but if the patient is on Medicare, use HITP. And then similar but not identical procedures, use HITPs. So I went through that before, but again, just a nice quick reminder for that as well. And then kind of just a takeaway regarding ICD-10s is that here the purpose of the ICD-10 is what the patient has or experiencing. The CPT code is what the medical professionals will do about their ailment, about the patient's ailment, and the HITP is the equipment, tools, and support services needed to fulfill the patient's treatment. So that's kind of like an easy, right from the ground understanding of why they all work together and how they all work together. And then super quickly, just want to go over some Medicare reimbursement. I know I only use a quick amount of time just for some questions, but we have to make sure that for Medicare reimbursement specifically, no category that's specific, there's no really category that specifically addresses substance abuse treatment. Instead, CMS provides services for substance use disorders only when reasonable and necessary. And I'm sure all of us are pretty aware of just the idea of just the minimum necessary and what's reasonable and what's not when it comes to submitting claims. For inpatient treatment, professional services can be reimbursed as inpatient stay for professionals, and they are not recognized specifically as separate billing. And then additionally, they can be reimbursed directly to the professional if they are covered under Medicare Part B and recognized as separate from inpatient stay. And again, medications are bundled into inpatient payment in regarding through the reimbursement process. Here, outpatient treatment, this is just for eligibility purposes. Here I just have some information regarding like some services can be performed by auxiliary personnel. Coverage and payment is based on service by service basis. Substance abuse treatment is not considered to be an independent provider type. So there's no integrated payment for the bundling of services. So it's kind of just what is provided, what code is just brought to the forefront. Let's see what else is there. This is a really important slide that I wanted to address. Medicare Part A and Part B. So Part A is for the inpatient treatment, and then patient would pay the same copays. Here again for Part B, pays for the outpatient treatment, and then this is usually administered at clinics or hospital outpatient departments. Other covered services, psychotherapy, expert, inpatient prescription drugs, outpatient prescription drugs that are covered by Medicare Part D. And so I thought I would just include that so you're aware of just other reimbursement covered services. And then this is a description of expert, but I don't think we have time to go too deep into that at the moment. But ultimately, there are additional resources if you're trying to get a deeper understanding of all of this. I would recommend AAPC.com, which is just kind of an academic association of medical coders. And so they keep up to date with all the information that CMS is releasing regarding that. And then there's a collaborative resource group that is kind of being done within Kentucky, Louisiana, Michigan, Pennsylvania, Texas, and Washington State. They're kind of, piloting this program similar to what IRHA has been focusing on and what a lot of our other partners have been doing and what some of you are already doing maybe yourselves. And so there's a lot of resources out there that exist of what people are doing already within the CMS funded world of coding. And so that's kind of really what I have at this point in time. I really appreciate all of you listening and just being here to understand and learn along with myself, who's been growing in this area. But are there any questions right now at this time?
Feel free to use the chat function or the Q&A function for any questions. Well, Micah, do you want to back up one slide and talk a little bit about SBIRT?
Sure, I can briefly. Hold on 1 second. My slide is not moving where I want it to go. There it is. Oh. So for SBIRT, this is actually an early intervention approach for people with SUD. Specifically, this one is structured assessment and brief intervention. Again, early intervention is always what's going to be necessary and helpful in assessing the issues that are going on within the patient's life and through their addiction journey. This is usually done within an outpatient setting and is founded on the 3 pillars of screening to assess their state, engaging with the patient, and referring them to treatment, whether that be therapy or additional resources, groups, and other housing options and different things like that. So the whole point of it is just kind of meeting them where they're at before they reach a level of severe addiction. And so it's kind of just getting into the door, getting a foot in the door before there's heavy dependency and before you may lose them to follow up. So this is a very helpful strategy that a lot of outpatient clinics may use through like a consultation method. And yeah, that's kind of what really SBIRT is like the main focus for. Let's see, are there any other questions?
Sayward, it's just you and one other person at the moment. So feel free to ask questions either in this setting or Micah, if you could put your information in the chat box for contact, that'd be great.
All right, M. Kassahun at indianarha.org. Perfect. Yeah, feel free to email me if you have any questions. I'd be happy to answer them to the best of my ability and also refer you to resources just within our network. But just thank you so much, everyone.
Thank you, Micah. I'm going to go ahead and stop the recording.
Sure, yeah.